Okay, I think we'll get started. So my name's Heather Strosher, and I'm the knowledge broker for the BC Support Unit Island Center, and I'm here with my colleague Uta, who will introduce herself later. And I just wanted to start off in a good way. So Uta and I are here at the Putting Patients First conference in person in Vancouver, which is on the Musqueam, Squamish, and Tsleil-Waututh nations. So I want to acknowledge the beautiful lands we are here. And this morning we were honored to have Elder Roberta Price open us up in a good way, and it was a really beautiful welcoming to Putting Patients First. So very grateful to be on these lands. And we have two wonderful presenters today from the island. We're going to start off with Dr. Colette Smart, who is Island Health Scholar in Residence for Mental Health and Substance Use, and she's a professor at the University of Victoria and also a clinical psychologist. And I'm going to pass it over to you, Colette.
Hey, thanks, Heather. Welcome, everyone. Really happy to be here. And yeah, I'm going to be talking to you a bit about research as repair, looking at patient-oriented research through a trauma-informed lens. So here on the island, I live fairly close to campus, so I always like to use our university territory acknowledgement, acknowledge and respecting the Lekwungen, Songhees, and the Esquimalt peoples in whose territory UVic stands, and the Lekwungen and Wasanic peoples whose historical relationships with the land continue to this day. And this is our wonderful First Peoples House on campus at UVic. So, just tell you a little bit about me. So, I'm a registered psychologist, psych professor, and as Heather mentioned, I'm the research scholar in residence for mental health and substance use at Island Health, and I broadly identify myself as a trauma researcher and clinician. Um, and I've been doing patient-oriented research for about 7+ years now. And it just seemed like a logical next step for me as somebody who's a scientist practitioner. And my research has always been informed by the lives of my own clients. And so to actually have people with lived experience on my research team just seemed like a natural fit. And I've worked with about 16 patient partners over this last few years on various projects related to the intersection between trauma and health, including trauma and brain injury following non-fatal opioid overdose, and also complex relational trauma and complex PTSD. And as one of my main patient partners, Laurie, always wants to emphasize, people think trauma is just a mental issue, but they don't realize how intimately interconnected it is with physical health and the need for trauma-informed healthcare. And so that's what I want to talk a bit about today. For those of us who are health researchers, it's really important to be thinking about trauma-informed practice. It's really relevant to everybody's research. And I want to give a special shout out to the BC support unit, including both Heather and Utah that I've worked with, who've been absolutely integral to the work that we've done and walked with us every step of the way in terms of recruiting, onboarding, and supporting our patient partners through our projects. So, we had some presenters had some questions that we were asked to reflect on. So how patient and community engagement enriched our research. So much of the work we've done is broadly with people that would be classified as marginalized or hard to reach populations. And so in that kind of situation, it's really an ethical imperative, I would say, to have patient and community engagement to ensure our work is relevant and the results are translatable. And it also increases credibility in the eyes of healthcare users to know that the work was done in collaboration with patient partners or people with lived experience. And really having those patient partners and other community knowledge brokers ensured that we did our work in a good way without perpetuating or creating stigma. And this was a really important message in every project we did, that the idea of stigmatization and marginalization. So having their voices at the table, patient partners, was really important. So I want to talk about this idea of research as repair. So If you know anything about Dr. John Gottman, who's a really well-known couples therapist and psychologist, he talks about as part of certainly couples, but really any good, healthy relationship that we have a process of rupture and repair. So there's things that don't go well in a relationship, and then we come back together and we make a repair. And so I was really reflecting on for this presentation how the process of patient-oriented research can be a form of repair and a do-over for people with lived experience that may have experienced harm within the healthcare system. And so I generally think about trauma as an experience of harm that's been caused through robbing a person of their control, agency, and autonomy. And sometimes that can happen outside of the healthcare system, but then healthcare can perpetuate or even cause some of those harms. And so I really see patient-oriented research as an opportunity to repair some of those harms, to repair the relational ruptures that have caused harm by working collaboratively with patient partners and making sure their voices matter. And I really want to underscore, bold, put a highlight around the relational aspect of this. So it's really not seeing patient partners just as a means to an end, but an end into themselves. And it's the relationship and working in a good way that's so important. And I've had the pleasure and privilege to work with a lot of Indigenous people in my clinical practice and learned so much from them about the importance of working in a good way and working relationally. And that's very important for trauma recovery as well, because we know that social support and social connection is such an important part of trauma recovery. So, really wanting to emphasize the relational aspect of working with patient partners and how important that is and how restorative it can be. So, some key lessons for effective engagement. So, like I mentioned, if you're a healthcare researcher, whether trauma is your focus or not, it's really valuable to consider a trauma-informed lens because trauma is very relevant to many people interacting with the healthcare system. So, many people don't know that there is a thing called medical PTSD. And when I opened my clinical practice, many of the people that I was seeing had undiagnosed medical PTSD following critical incidents. So people who've had stroke, brain injury, cardiac events, cancer, these are all conditions that increase the risk that somebody has medical PTSD. Also complex PTSD or complex trauma, such as that comes from adverse childhood experiences. We know that's well documented that people with complex trauma often end up with health comorbidities in adulthood. Um, we have a lot of newcomers coming to BC. So people who are refugees or have come from conflict zones, they've probably been exposed to traumatic stress, and that's why they've come here. And then they have to engage with a healthcare system, often in a different language and a different culture. And then people who may be from here but are from minoritized backgrounds who can experience harm in the healthcare system, such as Indigenous racism and people who are part of the 2S LGBTQ plus community. So all of that is to say your patient partners may have lived experience of traumatic stress. And so this is why trauma-informed practice is a useful approach in engaging with patient partners. So what is trauma-informed practice? Because it can be a bit of a buzzword. And I had a conversation with Tracy Nigro, who's my boss at Island Health, and we were talking about sometimes people think trauma-informed practice is just being nice to people. And yes, we always want to be nice to them, but there's a lot more to it than that. So there's really these four pillars of TIP that we talk about. There's different nuances to how people talk about trauma-informed practice, but there's somewhat of a general consensus that there's these four pillars of TIP. And so the first one is trauma awareness, so knowing what trauma looks like and how it can show up in a healthcare environment. Safety and trustworthiness, so being transparent, open, and reliable, having continuous informed consent, and establishing a felt sense of safety. That transparency is so important. I've been blown away by the number of people I've met who've had encounters with the healthcare system. They've had tests done, they've had procedures, and had no idea why. Nobody ever told them why they were having that test done, why they had to go to speak to that practitioner. Everything was kind of opaque. So just that act of being transparent is a huge deal, and we can bring that into our research as well. Choice, collaboration, and connection is the third pillar of tips. So thinking about ways to restore autonomy, fostering dignity and self-determination, and working together in a good way as a team. And then the fourth one is strengths-based and skill building. So it's really about substituting what's wrong with you to what happened to you, meaning what happened to you in your past that led to you developing these different ways of coping or being in the world. And this fourth pillar is really important because trauma-informed practice doesn't necessarily single people out as having lived experience of trauma, but it's really creating an environment that's welcoming to everybody, including and especially people with trauma histories, but really focusing on their natural resilience and their humanity. So that was one of the things that came across, I think, in every patient partner study that we did, that people with lived experience wanted us to know and convey through the research. We're more than just a diagnosis. We're a whole human being, and we have hobbies and we have interests and we have music we like and relationship and pets that see us as a whole person. And yes, we have lived experience in this one particular area. So I want to, there's so much I could say about this, but in fact, there's so much I could say, I put it in a video. So I created a whole video presentation that really walks researchers through the different steps of how they can bring a trauma-informed approach to patient-partner collaborations and research. And I'm delighted to say that Heather helped me in producing this video. So there's a QR code on the screen here, and you can actually go to my YouTube channel and watch the video. And like I say, it really walks through the steps of how you can use a trauma-informed approach to engaging with your patient partners. So in terms of some of the impact of our work, of course, traditional knowledge output such as published research and presentations. But another big focus of our patient-oriented approach to research has been thinking about more applied knowledge translation products. So this past summer, we actually developed a whole series of different websites that are targeted towards healthcare providers, community stakeholders, people, other people with lived experience, family and caregivers, to educate them about the different topics that we researched. And so there's actual tangible steps that people can do in terms of using the research. And so it's not just kind of behind the academic paywall in some journal. Um, and I feel very fortunate and privileged to have this position at Island Health, that I get to be the scholar in residence within mental health and substance use, so I can actually have a direct impact on implementing trauma-informed care here on the island. So one of the knowledge translation products that we just completed was actually initiated by a patient partner, a person with lived experience, Laurie Herod, who is a very well established advocate for complex relational trauma survivors. And so we created a digital healthcare toolkit that's meant to help educate trainees, clinicians, and administrators about what complex trauma is and how to take a more trauma-informed approach to healthcare. So we're going to be working with stakeholders here at Island Health to implement basically an e-learning course for people to actually educate themselves on trauma-informed care. And then we're looking at making that course available to people internationally. Laurie has already been working on an international dissemination of that knowledge translation toolkit, and we want to make this e-course part of that. So just want to thank some of my funders, supporters and collaborators, including the BC Support Unit, who's been absolutely integral to our work. And just to end with one of my favorite quotes, we're all just walking each other home, which I really see as the essence of patient-oriented research. You can scan this QR code that I believe has my link tree and links to some of those knowledge translation products that I mentioned. And I'm right at 15 minutes, which is good. So we have time for questions. Just going to stop sharing here.
That was wonderful. Thanks, Colette, and really on time there. Um, please feel free to put any questions in the chat, or you can also raise your hand and we can answer them there. And I just popped the video, the YouTube video that Colette mentioned. I popped that into the chat, and I'll also put in the link to the resource you mentioned that you developed with Lori. So if anyone has any questions, feel free to put them in the chat there, or just go ahead and raise your hand. We don't have lots of questions here. I'm just going to check the
Mhm.
Whova app from the conference. No, there's none in there either. Oh, Uta has a question for you, my colleague.
Colette, I was just wondering what it was like working with patient partners in developing the video. Were there some, was it easy or was that, how did they
Oh,
impact?
so I
Yeah.
should clarify that the video that Heather helped me work on, there's no patient partners in that. But the digital healthcare resource that we developed for Laurie and her community, we did create a series of YouTube videos for that, and Laurie herself is featured on there. So
Oh,
yeah.
and
Yeah, I
great.
mean, it's a bit challenging, like the pro and con now, of course, post-COVID, we can do so much work online. So many things can happen over Zoom, but it would be nice to be able to meet with people in person. But um, the other part of that is many of our patient partners live all over the island.
Yeah.
And one of our patient partners in particular lives way up north, and she always wanted to make sure that we had the consideration of people who um, are navigating healthcare in rural and remote areas. And so it was beneficial to have that input in terms of thinking about the practicability of our knowledge translation resources.
That's amazing. That's really nice to hear about the rural and remote engagement. I facilitate rural and remote, so I always get excited when people get engaged in those regions. That's great.
Yeah.
Okay, we have some questions coming in the chat now. It's taking people a few minutes to get them down. So the first one is, how might a researcher determine they are making an impact with their trauma-informed, co-creative approach? Typical processes and evaluation metrics don't really address the relational components. How do
Hmm.
you approach this, especially to health systems and health authorities? That's a great question.
Okay, I have to read that because my working memory is not so good.
That's a
It's
lot.
capturing the relational components. So in evaluation and the type of research you're doing, how do you capture those relational components to show?
Yeah, I mean, I guess so. It says, how might a researcher determine they're making an impact? Is that just for your own sake, or is it because you have to kind of prove it to somebody else? So, like, for example, here at UVic, one of our main focuses is community engaged research and community oriented research. So, they like to see that we're engaged in patient oriented or community oriented research. Um, and That's it's a really good question because it is hard to document that. Um, I mean, I guess asking for feedback from the patient partners just every step of the way and just really having this kind of horizontal sense. So really, like I talk about this in the video, one of the first things we do when we begin a new project is we have initial meeting, which is just a meet and greet and just get to know you and just kind of in a informal way. Of course, what's professionally appropriate, but something good about yourself and what helped you show up here today, what's your motivation to be a patient partner and just really having that sense of being collaborative and also making sure that our language is accessible because we can use a lot of jargon and academia, but um, yeah, and it's it's a good question. How do you document that? I'm not really quite sure. I don't know, Heather,
I've
do you
seen
have
it
thoughts?
I've seen it firsthand in your work, Colette, from interacting with the patient partners who are so authentically engaged in your research. So it's those qualitative components when you know you're able to reach them, and then that spread from the work because you're integrating the lived experience. Other people who are accessing the resources or the research can also see that authenticity. So I think that's the relational component. But it
Hmm.
is, I thought it was a great question in that sense of like, how do you show that to the health authorities or to the health system? But I think SPOR, patient-oriented research, has really been, that's part of the aim of it, right? And you can see being in the room here when we were at the keynote, there is such an impact from patient-oriented research and bringing in that lived experience. So it is spreading.
Hmm.
Okay, we have a few more questions to get
Okay.
to. So, how might this topic apply to informal caregivers differently from patients?
Yeah, that's a good question because actually some of our projects did involve caregivers. So, one that we worked on, one of my first big projects was people who had lived experience of brain injury and coexisting trauma. So we had people who were either had lived experience of a brain injury and trauma or who were a caregiver. And we also had adult caregivers and also caregivers of children. So we had like quite a diversity there. And so some of the resources that we developed actually had um, guidance and support and feedback for people who were informal caregivers, so resources for them in terms of how they could help their loved one advocate and navigate through the healthcare system. So yeah, I think caregivers of people with lived experience can be really valuable patient partners. Absolutely.
That actually leads really nicely into this next question. So it says, thank you for the presentation. Curious as to whether you have worked with parents of children with medical complexity who have medical PTSD, especially as many are not diagnosed with such, but live with it every day. So you did mention parents there.
Yes, so that, yeah, exactly. So that definitely did come up in that same project, which we actually did with the outpatient rehab team at Vic General. But that is, as I understand it, primarily an adult rehab. So the parents of children that we worked with were from the mainland. So those were I forget if it was GF Strong or what the children's hospital was, but yeah, they were mainly on the mainland. So one of the main things that we wanted to emphasize in that project is that symptoms of trauma can actually look like brain injury. And so sometimes when people are really struggling after a brain injury, they think, oh, it must just be the brain injury, not realizing it's actually co-occurring traumatic stress. And the thing is, traumatic stress is very treatable, including medical PTSD. And then that can get even more difficult to ascertain when you have kids because they express their feelings differently and communicate in different ways. So, yeah, I would really recommend if you go to my link tree, I think it's called Trauma and Brain Injury, a Practical Toolkit. So if you click on there, it has resources for parents and caregivers, and then it has some guidelines that we created. We worked together with that team of patient partners and caregivers to create consensus guidelines about what trauma-informed care should look like in a rehab context. So we produce those guidelines and then we actually have practical resources for parents and caregivers.
Oh, that's
But yeah,
great.
it's amazing how many people don't know, even colleagues of mine, that medical PTSD is a thing. Um, so I think there's a lot of Sunny Hill, yes, there's a lot of education that needs to happen around medical PTSD.
Mhm. Okay, we just have a few more minutes left for questions. This one's from Amanda Letty, who's an Island Health colleague of ours. And she says, thank you, Dr. Smart. I'm involved in a patient-oriented research project in long-term care and have observed that the research process itself has benefits to our patients who are often in care involuntarily and have very complex health issues, including mental health and substance use. I feel very strongly about this. Yeah, so less of a question, more of a comment from Amanda. And oh, here's the question. Is trauma-informed practice a topic that health research ethics boards consider when reviewing patient-oriented research applications? Maybe it should be. Oh, this is also close to your
Well,
heart, Colette.
it's very close to my heart because actually I'm going to be giving a talk on this because I am actually the vice chair of our ethics board here at UVic. And so I will often get to review those applications where there's a query about a need to look at trauma-informed practice. And again, because it is a bit of a buzzword and people don't necessarily know, okay, but like how do I actually concretely apply that lens? So I am going to be presenting at our ethics board next week for the reviewers to talk about what is trauma-informed practice and um, yeah, and so for POR applications, but even just for other regular research applications where they haven't included a patient partner, there's still a need to take a trauma-informed lens with certain populations. So yes, I'm going to be speaking on that next week.
Oh, fantastic to hear. That was from Amanda and from us as well. All right, any final closing thoughts from you, Dr. Smart, before we move on to the next presentation?
Yeah, I'm really just kind of in the back of my mind, going back to that initial question from DSFU. How do we document that relational piece? And I guess it's just the feedback from patients. And I've actually had a patient partners go from one study to the next because they had such a good experience with us that they wanted to continue on um, and to get the emails and follow up about how meaningful it was and being willing to promote and share the resources that we worked on. And I'm always fond of quotes. So I always think about Maya Angelou's quote, people will forget what you said, they'll forget what you did, but they'll never forget how you made them feel. And I think that's so important for patient-oriented research, just that feeling of walking together and we're really the horizontal, not vertical, that people often feel in healthcare with academics. And um, I think just the enjoyment, like also every patient partner we've had and we felt the same. It's fun. Like POR is fun, at least for me. I just find it so enjoyable and just satisfying. So yeah, it's hard to kind of document that for academic purposes, but anyway, it was a good question.
Yeah. Thank you so much, Colette. That was wonderful, and I think that was a great way to end it. Just the true value of pour when it's done meaningfully and authentically.